Great. Well, thank you very much for having me. I'm really excited to be able to participate here today. I'm actually feeling a little bit overwhelmed. I feel like a bit of a fraud because, I'm looking at all the names on the list and all the experts here. I'm not one of them, but I'm going to hopefully share with you the kind of flip side of what Sherry just talked about with regard to what are the kind of clinician competencies that are needed. And as Sherry alluded to, there's a boatload of evidence that this stuff actually works. We just haven't spent enough time really helping physicians, nurses, whatever, clinicians over their career to acquire these skills, and they're very useful skills. One other thing I'll say before I start is I think one of the things that's very important, again, in context of Sherry's talk, I feel this is really an obligation to make sure we help patients acquire the competencies they need to be most effective. And it's not just the patients, it's often families. I very much resonate with Jonathan's story. I literally had 3 parents now who are engaged in the healthcare system in various ways, some effectively, some quite dysfunctionally. And it's really interesting to place out. A lot of it has to do with just their understanding of even what's happening to them. And, I'm fortunate being in the healthcare world, I'm a filter. I'm an interpreter, to help them through that and balancing that. But it'd be pretty frightening to me to think about what if I wasn't there, and people who don't have that sort of resource to help them navigate, at times, a very overwhelming system. So let me just kind of give you a quick definition of competency. It's a term you heard from Lynn, and I totally agree. This is kind of an important concept, and sometimes it gets overused and people treat it like it's the Holy Grail, and then there's a lot of cynicism around it, but I think it's a really important concept. And it's really taken root in medical education, but I also think it has real value in continuous professional development. And this is a definition that was developed by a group of international folks. This is an international phenomenon. It's not just a U.S. sort of thing, but there's literally hundreds of countries who are embarking on trying to train the way they, or trying to change the way they train their healthcare providers. And it's really focused on outcomes, and it uses an organizing framework of competencies. And I think that's really important. The outcomes are really what matter now. It's not like, well, this is what we think is important. These are the outcomes that matter. I'll get more to that in a minute. But the competencies become a framework to help us make sense and help our clinicians be better. And I really love this slide. If this is the one thing you remember from my 10-minute talk, I would have you hang on to this from Julio Frank and colleagues from a Lancet article a couple years ago. And what they did is they took a look, and I heard Flexner alluded to earlier from Paul, but this is what we used to do. We had a curriculum developed by a bunch of experts sitting around a table, and then we would design tests. And that worked okay for 100 years, but it's not going to work moving forward. And what Frank and colleagues really called out that when you design any sort of educational system across the continuum, you start with what the health needs of the population are. That's what matters. And you talk about what the health system needs are. That's where you ground. And then from there you design the competencies outcome of interest. And then and only then do you really get into curriculum and assessment. If you don't meet the population needs, we've seen this disconnect, then it's not going to work, and you're going to get the system that we currently have. So what's a competency? And this is just, again, from that international group, easy way to remember. It's an observable ability of a health professional integrating multiple components such as knowledge, skills, values, and attitudes. I want to highlight attitudes matter. Attitudes are really important. We've already heard about culture, eat strategy every day for lunch, dinner, snack, breakfast. That's true. And attitudes are an incredibly important part of communication skills and patient engagement. So what are some of the kind of physician competencies that have been talked about? Again, these apply. I'm using a physician lens because of where I work. But these are the sort of things that, again, are evidence-based, and I'm going to call it just a couple of them. And yes, they're written in a list, so I don't want to leave you with the kind of belief that, yeah, you just check these off and you're fine. No, these are highly complex. They have to interact to be most effective. But they're helpful things to kind of keep, again, as a framework in mind. So just learning literally to set agendas with patients, it would seem like such a simple thing to do. But I can tell you, and Sherry knows this well, most clinicians don't do it. They just plow right into their visit. So, Mrs. Jones, you're here for your blood pressure today. It looks like it's still a little bit high. I'm going to adjust your medication. I'll see you in 3 weeks. Is that okay? Done, right? It's a very doctor-centered sort of approach. Instead of like, what's important to you today? What are you coming into the visit with? And there's a lot of good data that very simple act of negotiating the agenda with the patient, which doesn't take more time, getting to Sherry's point, makes a big difference in the visit. And then things like communicating treatment plan, managing conflict, and then family and caregivers, all these things that you've already heard about. Shared decision-making, this is just, again, a definition, why it's important, but it's really about partnership. So getting to Christine's, partnership, collaboration, team, right? And again, you have to incorporate the patient's values, beliefs, and preferences as part of that process. And as Sherry points out, patients will have varying amount of interest in playing various roles within the conversation. And one of the things that often gets forgot is that there's certain parts of the visit that are a little different. Patients actually don't want to be involved in the problem solving as much as they want to be involved in the decision making. And Raja Deborah some years ago nicely called those two things out. Problem solving is why they come to see you for the visit, whether it be a nurse, nurse practitioner, physicians. They want you to figure out what's going on. But when it comes time to make a decision, most patients want to be involved to some degree. And what the clinician has to figure out, what is that degree and how to help them do that. And then I'm not going to go through the evidence again. Like I said, there's a ton of it. What about some of the process basics? This is just a really nice article from Clarence Braddock. These are just 7 things, very basic. They're not complete. Michael Berry, who I see sitting in front, is one of my heroes, can tell you a lot more about the nuance around these. But this study that was done about 10 years ago found that only 9% of the time did physicians even cover these 7 basic things. That's it. And that's only if they did it, not if they even did it well. And so it goes to show you that these are things you would think would be important when you're considering a procedure and a medication. What are my alternatives? What are the pros and cons, the side effects of what I'm taking? Is this really going to help me? Is there a chance it might not? Thinking about joint replacement therapy as an example. What does the patient understand? There's some simple techniques you can use like teach back, getting them involved. All these things which, again, don't require a fancy tool, just part of good care and good conversation can make a difference. And then some nice work done by Tal and others that's also highlighted in the recent health affairs. These are just some other competencies really targeting the kind of shared or informed decision making. Again, the attitude and skills are important. But here's another thing that's been shown in the literature. Many times we have to negotiate our own professional biases and emotions. We tend to frame things hoping for the outcome we think is important, right? Yeah, you really don't want that niacin, what you really want is that statin, because you know that niacin has all these nasty side effects, but that statin's great, you don't take it once a day. And that framing can actually greatly affect what patients choose to do. We have to be careful about that. Again, partnership, making sure the patient's preferred role is clear. That's part of the negotiation that we often forget about. And then again, when you present the evidence, just simple things like not using jargon, making sure it's done in understandable terms. And again, watching out for those framing effects. So I'm going to stop there and just want to give you kind of a quick run through. I just highlight a couple other things I think really relate to the first talk. All these kind of behaviors, these things that are very competency-based and behavioral-based, they all tie in, by the way, to things like connectedness, continuity, and empowerment. It's been shown to be a very important part of that. We also know these very same competencies can be used in a team-based kind of model. And so Laguerre's work, which was highlighting some of the articles in the health affairs, really gets at that. And at the end, all these things have to interact with regards to the clinician competencies, the patient competencies, and the system competencies. And Beth Bernabeo has a nice article that really lines up how those 3 things need to interact. It's not an either or. All 3 have to work in concert to be most effective. So I'm going to stop there and look forward to the conversation. Thank you.